Great, welcome back. Thank you for everyone joining us for Wednesday conference.
Is that on?
Sorry, let me turn the audio on.
We'll just talk louder too.
Okay. Welcome back for everyone from the break. I will be talking about Crashing Tamponade. I will still call myself a junior faculty member since I'm introducing myself today. I've recently been told I'm no longer junior, which is to my chagrin. I am an assistant professor here at University of Maryland, Department of Emergency Medicine. I am also one of the assistant program directors. And obviously, I love cardiology. I did a fellowship following residency here in cardiology and then stayed on as faculty, and I'm here at the University of Maryland. I have no disclosures, and we're going to start with a case that I had actually subsequent to fellowship here. And let's first start with trivia. And I know I have Dr. Liu here who loves trivia. So this physician is a Canadian physician, spent the latter part of his medical education and life here in the States, specifically here in Baltimore. And what did he say about cardiac tamponade? He said that there is no serious disease so frequently overlooked. And why did he say this? Tamponade, in fact, is a continuum, a spectrum that starts from fairly asymptomatic to quite symptomatic, and we're going to talk about that today. And we're going to talk about the different etiologies, specifically traumatic and surgery, secondary to trauma or to any type of procedure that's happened, or medical, the larger box that we see, and we'll go from there. Does anyone know who this might be? Or Mimi, you know? Yes. Good. She said Beck, and this is actually Osler, and we're going to get to Beck shortly. Why was Osler so important? Osler was so important because he not only was a forefather of medicine, but he was the first to take patient or students from the bedside to the from the bench to the bedside. And what did he actually create? He created medical residencies. He said patients need specialists in different fields. And so this is what he was known for, and he, a forefather here in Baltimore, one of the founders of medicine, first physician-in-chief at Hopkins across the street. So this is Miss Mary. Miss Mary came to the emergency department with a chief complaint of dyspnea. And what you note about her vital signs, she's afebrile. Her blood pressure generally runs from 100 systolic to 110, so she's a bit hypertensive from her baseline. She has a mild tachycardia at 105, respiratory rate 18, a bit tachypneic, and slightly hypoxic, but Miss Mary is known to have lung cancer. Miss Mary is also known to have recurrent pleural effusions requiring drainage. She's followed by CT surgery here at university, and she has a thorax catheter. And every other day, she drains about 150 cc's to 200 cc's, so she doesn't get dyspneic, and so she doesn't have to come to the ED and get her pleural effusion drained. So I met Miss Mary when she comes in for a chief complaint of dyspnea, and I asked her, you know, what's going on today? Are you draining your catheter appropriately? Is it being clotted? Are you having blood clots that are hindering you from having appropriate drainage? And she said, no, in fact, I'm draining it, and now I'm even draining 100 to 200 every single day because in the last week, I've been more dyspneic than usual. In triage, they astutely got an ECG on her, and if you'll note here, she's quite tachycardic. For her baseline in the past, her heart rate is in the 50s to 60s, so here you see a difference. And of course, we're talking about tamponade, and tamponade has a lot of triads. The triad of the ECG typically is sinus tachycardia, low voltage, and electrical alternance. What you note here is this patient, who does end up crashing, and we'll discuss her later and how she crashes, in fact, does not have low voltage, nor does she have electrical alternance. So the most common thing you're going to see is sinus tachycardia. And so what do we hear about, or what do we know about the term classic? It means it happens about 15% of the time. Not only does it mean that, it means if you wait for your patients to have these triads, you are going to wait until they are ominously or heralding a collapse. And you don't want to do that. Let's look at an ECG that's more classic. So this ECG shows not only sinus tachycardia, but it shows low voltage, which is described in the limb leads and the precordial leads a little bit differently. In the limb leads, if it's less than 5 millimeters in amplitude, and the precordial leads less than 10 millimeters in amplitude. And then when you talk about electrical alternance, it's a beat-to-beat variation. And so I will show you guys here, this beat compared to this beat. Here, up, down, and that is the swinging of the heart back and forth. So again, electrical alternance, although the most specific sign, is the least commonly seen, so don't wait for this to be seen in your patient. Miss Mary had an x-ray done, giving her, again, continued dyspnea. And what does it show us? It shows us a large heart, probably, but a large left pleural effusion, which is kind of obscuring the heart, and a meniscus. This is not uncommon for her. She's had several chest x-rays in our system that look very similar. All right, so we threw an echo probe on her, and what do we see? We see a star in the middle here, and the star sign is indicative of the descending aorta. And so what do you see anterior to the descending aorta? You see an anechoic structure, and that is her pericardial effusion. And what do you see posterior to the descending aorta? A pleural effusion. Okay? So we're going to remember that mark when we go on to look at more echoes of her shortly. So given that Miss Mary is well known to CT surgery, we consulted them and said, hey, the patient's here. She's well known to you guys. Can you come to the ED and see her? That being said, we were also very concerned because she has a new pericardial effusion, and despite frequently draining her thorax catheter, she continues to be dyspneic. And we're going to go on to more specific echo findings that we saw, which was concerning for tamponade physiology. So we have two consultants in the ED here down to see her, and of course, as physicians, even amongst our own colleagues, we often don't agree. So cardiology was thought this pleural effusion, the pericardial effusion was likely not causing her dyspnea. CT surgery also thought likely her pericardial effusion just needed more drainage, although she's been, again, respectively increased from every other day drainage to everyday drainage, and it still wasn't improving her symptoms. Now, in emergency medicine, we're known to be the jack of all trades, and I would say that we are because we're very good at pattern recognition. So when you look at these different things, I want you guys to think, what is the first thing that comes to your mind? Travel blogger, leg pain, dyspnea. I think most would say pulmonary embolism. Night sweats, weight loss, hemoptysis, tuberculosis, periumbilical pain radiating to the right lower quadrant, appendicitis, headache, vomitus, syncope, whether abrupt or not, subarachnoid. That being said, sometimes we anchor in the emergency department as well. So the problem is that we must make sure we don't miss the forest by looking at the trees. And so I'm not going to talk about hooves, as Dr. Lu discussed, meaning horses versus zebra. I think that everything that we kind of see in the emergency department should be at the forefront, and sometimes anchoring, unfortunately, makes us miss things. And so we're going to talk about the most common etiologies that mimic pericardial effusion and tamponade, and how we can make sure that we're not missing it. So let's rewire your brain and go back to those cases a second ago. Travel blogger, leg pain, and dyspnea could also be echinococcus. Night sweats, weight loss, hemoptysis can also be malignancy. Periumbilical pain radiating to the right lower quadrant can also be tephlitis. Headache, vomitus, syncope can also be CO poisoning. So all these things are quite important and not to be dismissed as zebras. Likewise, we're going to talk about dyspnea. Dyspnea is the most common sign and symptom that your patients are going to come in with. And not only are they going to be dyspneic, many patients that we see in the emergency department are going to have a subacute tamponade. Unlike the acute tamponade that we often hear about, and we're going to discuss the difference between the two and why triad, such as Beck's triad, is not what you should be looking for. Although it is something that the boards will ask you, and although it's something that's the FNM that we should remember, recall that, again, our cases of tamponade are going to be medical and therefore subacute. So when you have a dyspneic patient and they have any type of hepatic congestive hepatopathy, as we call it, meaning they have abdominal girth, lower extremity edema, platypnea, orthopnea, fatigue. You're going to think of two things most commonly, and I think we all know heart failure. We see that a lot here in cirrhosis. We're a liver transplant center here. So we see many of these patients, but I want you to think, when you have a dyspneic patient that has congestive hepatopathy, lower extremity edema, any of these type of symptoms, you need to think this person may have tamponade. All right. So let's talk about the pericardium. Pericardium has a visceral and a parietal layer. This is a potential space similar to the pleural space, right? You have a parietal and visceral layer. And in this potential space, it's usually negative pressure. So the intrathoracic or the pleural space is negative pressure. Likewise, the pericardial space is under negative pressure. So what happens? There's usually 25 to 50 cc's of ultrafiltrate of plasma that's a natural shock absorber for the heart, and that's normally what's there. What happens now when your intrapercardial pressures increase, in fact, they increase above the diastolic filling pressures of the ventricle. And shortly after that, what happens is you have an increase in your left-sided chamber pressures, and we're going to go through another diagram shortly, kind of going through the pathophysiology. But think about intrapercardial pressure being negative. When it becomes positive, it then can overload diastolic filling pressures. When that happens, it will affect left-sided filling pressures, which ultimately will affect your stroke volume and cardiac output. That's when we have a problem. So we're going to go on to Beck now. Beck's triad is better known for JVD, hypertension, muffled heart sounds. Now, Beck is a cardiovascular surgeon. So where were his kind of cases accrued? Post-mortem, so autopsies of people that came in with trauma, cardiac trauma. And so when you think about Beck's triad, it is describing acute tamponade. And acute tamponade, it is a small volume of fluid, not the rapid rise with a small volume, as opposed to the medical type of tamponade we're going to discuss, which is much more subacute. And so the rate of rise is much slower, and so the amount of volume that can be accrued in the pericardial space is much larger. So again, Beck, not only himself describing trauma, you can also think about any pericardial or cardiac surgeries. So an ablation, a box or AICD being placed, any type of cardiac or heart procedure, in addition to trauma, can cause low pressure or acute tamponade. Now, what is the kind of bread and butter we're going to see in the emergency department? They're going to be malignancies by and far here in this country, and then if you take into account not only developed but also third world countries, infectious etiologies, TB being the most common. Here in the U.S., we think about Coxsackie often, but any type of viral etiology. In addition to that, don't forget about inflammatory metabolic conditions, specifically hypothyroidism is another one. Specifically under, metabolic conditions. With inflammatory conditions, you have lupus being very common here. You have HIV and the sequelae of the ART medications and the inflammatory process that they have. In addition to that, Dr. Dubs talked about medications such as danirubicin or doxorubicin. Malignancies, in addition to the treatment of those malignancies, are important, and then other systemic diseases such as uremia, which is also quite commonly seen here. So again, when you think about trauma and surgery, that's an acute tamponade, and we're going to talk about the difference in hemodynamics that you see there versus a subacute tamponade. Subacute tamponade being all the other jargon that we just talked about. What is a regional tamponade? Regional tamponade is often seen with people that have either had an MI, right? So it's contained to an area in which the infarcted wall is, or again, you had some type of pericardial procedure like an ablation. And so those are often quite difficult to see, and you won't necessarily see them with TTE, but if you have a high suspicion, you'll be getting a TEE. And then low pressure tamponade is usually in people who are hypovolemic, have had trauma, or otherwise aggressively diuretic. So here on the left, you see what is the sine qua non of an acute tamponade that presents with JVD, hypotension, local heart sounds. You see that it is the rapid rise there, even though there's a small amount of fluid accumulating, as opposed to on the other side, here you see that the rate of rise is much slower, and then you don't get tamponade physiology until much later. And in the, under that circumstance, you can develop several liters of fluid in the pericardium. So what's important? Rate versus size, as we just said, it's the rate of rise. You can have a small pericardial effusion cause acute tamponade. You can have a very large pericardial effusion cause tamponade in the subacute setting, and that's typically, again, what you're going to see, and so you're going to see a lot of third spacing secondary to that. When we talk about the hemodynamics, there are three phases of the hemodynamics. So the yellow line that you're seeing is the intrapericardial pressure that's initially negative. Then once it rises and it affects the diastolic filling pressures, it equals the right side of the heart filling pressures. That's where it equals meets the blue line. And then finally, in the second phase, it's going to meet the red line, which is affecting the left ventricle or left-sided pressures. That's where you have interventricular dependence, as we're going to talk about shortly. And then finally, cardiac decompensation. So if you talk about phase one, that's here, and often people don't have any hemodynamic effects. In phase two, you have a catecholamine surge because your heart is aware of the pressure, not only on the right side, but now impending on the left side. And what happens here? People get tachycardic, but surprisingly, not only do they get tachycardic, they also get an increase in blood pressure. So not the hypotension that you would expect to see. And why is this? You have the catechols, which cause your SVR, your systemic vascular resistance, to clamp down, right? It doesn't like what's happening. And then finally, after you've completed left-sided equalization, what happens is you have phase three. So again, phase one, no real change in hemodynamics. Phase two, tachycardia with in fact hypertension, not hypotension. Phase three, when you see hypotension, and that is often an ominous sign. So in subacute medical tamponade, you in fact will likely see more hypertension as opposed to hypotension, which is more likely in regional and acute tamponade. So in our patient, Miss Mary, you saw that she was slightly hypertensive above her baseline. That is not uncommon. All right. So we know there's this thing called Pulsus Paradoxus, and I think all of us do it all the time in the emergency department, right? No, I see all the heads shaking, no. All right, so it's like a foreign language to us, so let's quickly go over what it means. You need two things. You need a stethoscope and a blood pressure cuff. And what you're going to do is you're going to take the blood pressure cuff and you're going to go all the way until you can't hear any karat cough sounds and slowly come down. You're going to come down until you hear the first karat cough sound. That's your first systolic blood pressure. And then you're going to slowly decrease it until karat cough sounds are completely, go from intermittent to continuous. So again, you're going to blow the blood pressure cuff up until you can't hear anything. slowly come down. You're going to hear the first Karat-Ka sound. That's your first blood pressure to measure. Those Karat-Ka sounds are just intermittent. And then as you slowly come down, the Karat-Ka sounds will be continuous. As soon as they become continuous, that's your second systolic blood pressure measurement. The difference between the two is your pulses. Normally, when you inspire, what happens? You get negative pressure, right? Negative intrathoracic pressure, negative pericardial pressure, and then fluid goes back to the right side of the heart. You increase your preload. And when you increase your preload, your blood pressure is going to come down because all the blood is going into the RA and RV. So it's normal that the blood pressure decreases. What happens, though, when you have a increasing intrapericardial pressure, when you take this deep breath, the RV is now impeded. Not only is it impeded because you have intrapericardial fluid building up and pressure accumulating there, but now when you take that deep breath and fluid comes into the RV has nowhere to descend. The free wall is not able to kind of comply. The compliance there is down because you have fluid within the pericardial space. So the intraventricular septum bulges into the LV. So what happens when the intraventricular septum bulges into the LV? You have a smaller chamber size, so your stroke volume is decreased there, and therefore your cardiac output will be decreased. So Pulsus Paradoxus is not paradoxical, it's actually an exaggeration of what normally happens with inspiration. And why is this so important? Because often it's thought to be pathognomonic in tamponade. In fact, it's not pathognomonic in tamponade. You can see it. It's first been coined in lung disease. So you see it most often in COPD and asthma, actually. Where else can you see a Pulsus Paradoxus? If a person is profoundly hypovolemic and septic, you can also see it. If a person has a PE, you can also see it. So it is not pathognomonic for tamponade, although it can be seen. Finally, are there any reasons that a pulsus can be absent? Whenever your filling pressures are high, such as aortic insufficiency, atrial septal defect, high left ventricular and high left ventricular end diastolic pressures, a saddle PE, all of those reasons that increase pressure are going to cause your pulses to be absent. So should you do it? Sure. Would I take the time to use a blood pressure cuff and my stethoscope to listen for it? I likely wouldn't. I would either, if the patient is hypotensive, have an A-line in and look at the beat-to-beat variation, similar to what you do with sepsis, or simpler, you can use your pulse ox. The bottom of the screen here is the pulse ox of a patient, and if you see beat-to-beat variation, more than 25%, you can assume that they have a pulse. Pulsus versus Kussmaul. So Kussmaul was a physician who coined the term Kussmaul breathing, right? We think about Kussmaul breathing with DKA. Now, what is a Kussmaul sign? Kussmaul sign, in fact, means when you take a deep breath, instead of your JVD going down and the blood pressure going down about 10 millimeters of mercury, which is about normal, that doesn't happen. It, in fact, increases. That's pathognomonic for constrictive pericarditis, not the pericardial pathology we're discussing today. So pulsus is not pathognomonic, but more commonly seen with pericarditis and large effusion. Kussmaul is not seen with tamponade, it's specifically seen with constrictive pericarditis, so don't confuse them. Finally, what do we go to as a diagnostic tool? What's essential is an echocardiography. What must be remembered is echocardiography can be very subtle, and before you have clinical signs or symptoms, your echo may be positive, and that's not when you want to intervene and do a pericardiocentesis. In fact, that's when you want to look at the clinical picture. So tamponade is not only a clinical finding, it is something that is supported by an echo diagnostic tool. And so here, what do we see? I'm going to replay this for you guys. You see apical four-chamber, kind of foreshortened view. You see a large pericardial effusion, and we're going to talk about kind of the different things you want to look for. Now, how do you remember if something is diastolic or systolic collapse? All you need to think about is what should the chamber be doing during the phase. So in diastole, the ventricles are receiving blood, right? So that's when they should be filling up. Likewise, in systole, the atria are receiving blood, and that's when they should be relaxing to receive the blood. What happens is, paradoxically, instead of in diastole, the RV receiving blood, it has pressure in the intrapericardial space pushing against it, and it can't receive the blood it should be getting. So the RV in diastole, when it collapses, is abnormal. Likewise, the RA in systole, when it should be receiving blood and filling, relaxing, it's not, because you have fluid impeding on it, okay? What is more sensitive and specific? The chambers on the right side obviously are not under a lot of pressure, meaning the pulmonary circulation is very different than the systemic circulation. And so when you have intrapericardial pressures increase, the right side is what is affected as opposed to the left side, which can handle a lot higher pressures. The RA is more sensitive and easily affected. However, it's not more specific. The RV is more specific. If the RA collapses during diastole, that's important. More importantly, if it collapses for a third of the entire cardiac cycle, that's more specific. So the longer your chambers collapse, the more important they are. All right, so I'm going to play this one more time for you guys, and you guys can see here both the RA and the RV are contracting. Now, this is going very fast. The patient is very tachycardic. What can you do to kind of slow this down? You just freeze and cynic scroll on your ultrasound. You look at the mitral and mitral valve or the tricuspid valve opening and closing, and you can just kind of cynic scroll until you find it opening and closing to figure out, is it diastole or is it systole? Likewise, you want to get a picture of the IVC. You want to look to see if the IVC is plethoric, and you also want to look at the hepatic veins if you can. Much more difficult in patients with tamponade. You can only see it in about a third of patients. But you want to see the size, plethora, and you want to see if there's any respiratory variation. Okay? We're not going to go into hepatic vein reversal looking at that, but we are going to go a little bit into Doppler and why Doppler is important. So Doppler is the surrogate of a Pulsus Paradoxus. You're looking at inspiratory and expiratory changes across the valves, and you're looking at the gradient. So as we discussed with the pulse ox or with Pulsus, if you have greater than 10 millimeters of mercury, an exaggeration, a change there greater than 10, that means you have a Pulsus. Likewise, if you look with pulse wave Doppler, so you're going to get a picture of the four-chamber, right, apical four-chamber, and you're going to put your pulse wave Doppler either over the mitral valve or the tricuspid valve. More commonly here, we use the mitral valve in our echo lab. I mean, they do all the measurements, but the number range is much smaller with the mitral valve. You want to look for a 25% change with inspiration and expiration to see if there's, in fact, a pulsus or the Doppler equivalent of what a pulsus would be. Now, people say, well, how do I know if it's expiration or inspiration? Do I need to put the ECG leads on? In fact, you don't. You just need to make sure you're sweep while you do the picture, so meaning the maxes and mins, you have a number of them there. You want to take the highest number and the lowest number and take the difference amongst them. If that's greater than 25 to 30% on the mitral side as opposed to about 40 to 50% on the tricuspid side, that is indicative of what a pulsus would be. All right, so do you want to do a 2D versus a Doppler? I would say you want as much information as you can get because as we just said, ultrasound or echocardiography is overly sensitive. And tamponade is not only an echo diagnosis, but a clinical diagnosis. So the more pieces of information and the more pictures you have, the better it is to convince yourself, and not only yourself, but your consultants, that this is an emergent process that needs to happen. Now, the European Society has a consensus statement. We're not going to kind of go through all this. I want you to know that there are three parts of it that are important: the etiology, the signs and symptoms, and the imaging. And why that's important, this is what likely tells you the person needs an emergent, meaning within 6 to 12 hours, decompression or evacuation of pericardial fluid versus they can wait 24 to 48 hours. The number here to remember is 6. You can go back and look at this later. Not important for us because you're going to use, again, the clinical picture, hemodynamics that are changing, and then your bedside echo skills to kind of make that determination for yourself. How do we temporize these patients? 3 kind of things. When you think about emergency medicine, you have the ABCs. We're trying to affect those ABCs. Now, your patient, like our patient, may be slightly hypoxic. She was to 92%. They may even be hypoxic to the high 80s. Now, what do you not want to do? You don't want to give them positive pressure. We just said that the right side of the heart is under stress because the intrapericardial space doesn't allow the free wall to bulge out. When you get more fluid, or when you take a deep breath, what in fact happens, your intraventricular septum limits your LV from having more volume. The smaller chamber, decreased stroke volume, decreased cardiac output. So any positive pressure can also worsen this. If a person is hypoxic, I recommend nasal cannula, a Venturi mask, or even high flow nasal cannula can give them a little piece. But I would not recommend non-invasive nor positive pressure ventilation. IV fluids versus diuresis. As we just said, when you give fluids or when you take a deep breath, you have this exaggeration, you have this Pulsus Paradoxus presumptively. And if you give IV fluids, what may happen if you have intraventricular dependence? Increasing fluid, if you think about a right heart failure patient, can worsen your hemodynamics because you're pushing this intraventricular septum over to the left even more. So in fact, you see these right heart failure patients that come in, and it's kind of scary because they're hypotensive and you want to diurese them. In this case, I won't recommend diuresis because what needs to happen again is evacuation. But I would say in about a third of patients, giving a little bit of fluid is important. Judicious fluids, 250 cc's to 500 cc's, has been shown to be efficacious and not drop hemodynamics. What's important in that population, they said it's usually in patients that have a systolic blood pressure less than 100. Okay, so our patient had a BP of about 130s over 70s. I would not, in her case, have given her fluids. When she got hypotensive, she did receive a little bit of fluid. Diuresis, answer here is no. Evacuation is answer. Finally, inodilators versus vasopressors. When patients get hypotensive, what should you be doing? Now, if you want to look at the literature, which is scant, I would say the most important thing is to know the literature says inodilators. why might you think, when you think about the pathophysiology, this won't work? A person has already had the catechol surge. Phase 2 of the cardiac cycle, when you have tamponade physiology, has shown that you get hypertensive and you get tachycardic. So imagine a septic patient coming in hypotensive and tachycardic. Giving full-dose induction agents has been shown to sometimes take them off of their catechol curve, and they in fact get precipitously more hypotensive. So you may see resuscitationists tell you to half-dose induction agents if you think a person is in septic shock. Likewise here, I would say if you're going to choose an agent, and I know dilator specifically, I probably would go with epinephrine as opposed to dobutamine in case they get more hypotensive, and you can change from low dose, which is more inotropic dosing, to higher dose, more vasopressor dosing, if that makes sense. The inotropic dosing is about 0.01 mg per kg per minute. Okay. This patient, Osler came to my bedside that day and said, listen to the patient. Miss Mary said that this is not her pleural effusion. In fact, she has been draining her fluid and it's not working. To her chagrin, the consultants were not on board. They decided to drain 500 cc's of her pleural fluid, and she had a cardiac arrest. 20 cc's of fluid was taken off, and then she had return of spontaneous circulation. Luckily, and I want to discuss one last thing before I go over pearls, pericardial decompression syndrome. What is that? And so it is what happens. There's 3 hypotheses as to why it happens. Let's first talk about that. A hemodynamic hypothesis, an ischemic hypothesis, and finally a catechol surge hypothesis. More importantly, what happens? You drain a large amount of fluid, and there's about 50 case studies that have been shown to kind of give this literature, or where this literature comes from. There's about 50 case studies. It's been shown that when you drain about 500 cc's to up to 1 liter, you have a change in the catechol surge. Your left heart is used to seeing a small volume, small chamber, because the right heart has been under pressure. Your filling pressures have been elevated. And what happens is when you reduce the pressure now, when you evacuate a large amount, people go into cardiac shock, cardiogenic shock, or myocardial study, in fact. And so what do you do about it? You support them through that, whether that means they need, again, inodilators, diuresis, intubation often. And so what you want to be cautious of is taking large volume of fluid, whether that's in the pericardial space or the pleural space if you have 2 concomitant effusions. And if you look at all the patients that have had pericardial decompression syndrome, most of them have biventricular failure. A small minority of them have specifically only right ventricular failure. And then about 40% of them will have pulmonary edema without shock symptoms, so without complete failure. So with large evacuations, beware of myocardial stunning. I'll take questions at the end because I'm over time, but let's review the pearls. It is the rate of the effusion, not the size of the effusion, that determines tamponade physiology. Small effusions, meaning acute effusions, happen rapidly. Subacute effusions happen chronically. Hypotension is a late ominous finding. If you wait for that, your patient will have cardiovascular collapse in front of you. You want to be more prepared. So, in fact, look for hypertension and clinical signs and symptoms. Pulsus Paradoxus is not pathognomonic. There are reasons you can have it, and there are reasons you cannot have it. It is quite a cumbersome thing to do at the bedside, so what I would recommend is using a surrogate. If the patient is hypotensive, use an A-line and look at the differential. Otherwise, use your pulse ox. Echo is a tool that helps in the diagnosis. It does not make that diagnosis. You need clinical signs and symptoms before you decide to drain a patient. When you talk about temporizing, recommend going with nasal cannula or high flow as opposed to any positive pressure, which will worsen hemodynamics. Have judicious use of fluids, to only use them in people that have a BP of less than 100 systolic. And if you're going to use medications, I would likely go with an inodilator, understanding that their catechol surge is at its maximum when they're in phase 3 and going on the lower dose end. And then have a lot of caution when you are draining large effusions because it does cause cardiac stunning. And finally, I didn't get to say this in the beginning, but we are all thinking of our coworkers, our colleagues, our friends during these difficult times, and we're in this together. So thank you for being here with us today.